Have you started? So when we start talking about malformations about the nervous system, the peak time of when the birth defects tend to be induced is around 3 to 8 weeks of gestation in the embryonic period. So you can see this is a graph which is in from the medical textbook of embryology by Langman, that the peak birth defects happen around 4 to 5 weeks after conception, and then it goes down. So this is another way where we can see here in the first 2 weeks, if anything happens, it usually is very lethal, and the pregnancy does not proceed. When the pregnancy does proceed, 3 to 8 weeks is the time of the greatest period of sensitivity, where you can have teratogenesis which can occur because of any particular exposure in different ways, and each organ system has its peak period of sensitivity, and the nervous system is one of the most important thing that you have to know. And then as time goes on from 9 to 38 weeks of gestation, the overall sensitivity to teratogenicity gradually decreases while the functional maturation is occurring in the baby. So when we talk about nervous system malformations, first we need to know what the normal development of the nervous system is. So when we're looking at the normal development, the gross outline is in the first 3 to 4 weeks of gestation, the primary neurulation or the neural tube starts to develop at the first 4 weeks. Then the prosencephalic, which is actually the development of the cerebral hemispheres and the central nervous system, which is in the first 2 to 3 months of gestation. Then side by side, you have the neuronal proliferation and migration, which occurs around 3 to 5 months of gestation, where the neurons proliferate, migrate, and form the various sulci, gyri, areas, various organ, various parts of the cerebral and the cerebellar hemispheres. And then finally, organization, which begins somewhere around 5 months of gestation and continues several years postnatally. And myelination is the final thing which begins at birth, and then that also continues to over a year or more postnatally. So that's the overall gross outline of normal development. So I'm going to go over a little bit of each, and you can see how the development, when it gets affected, you can get malformations. So the first step is formation of the neural tube. So before that, when we talk about the neural tube formation, you're talking about the first, very first step which happens is called gastrulation, where when you form the embryo, it forms the trilaminar plate, which divides into the endoderm, mesoderm, and ectoderm, and that's how the development begins of the entire whole baby in general. The nervous system begins with the first step, which is called neurulation, which forms the neural plate, and that gives rise to the neural tube formation, which gives rise to the entire central nervous system. The primary neurulation is formation of the brain and the spinal cord down to the sacral level. And then the secondary neurulation is the sacrococcygeal segments of the spinal cord. So when you're looking at it pictorially, gastrulation is where you have the trophoblast, and then it divides into the amniotic cavity, where you can see the ectoderm, then endoderm starts to develop, and then the mesoderm. And then at the same time, you start to develop the primitive streak. This is in the very first couple of days of life after conception. And then when you start looking at it, the primitive streak starts to extend into so this is a superficial view that you're looking at in the first 18 days, and then it starts to fold, the neural plate starts to fold and forms the neural groove and the neural tube, which will proceed after 20 days to go further on and form the neural tube, which is the spinal cord. If you're looking at the cross section, you're looking at the neural plate here, and you're looking at the mesoderm and the notochord. The neural tube starts to fuse, and then this green forms the neural crest, which will form the neural crest cells, and then the ganglia, etc. The ectoderm will form the superficial covering. The mesoderm will form the spinal column, the actual spinal vertebral processes and other things. And then the neural tube is protected within these vertebrae, which we see here. The more important things that we need to remember, practically speaking, as well as for day-to-day practice, as well as for your exams, is the fusion of the neural tube, which occurs from center to dorsal and posteriorly. So the dorsal ones close earlier, and the spina, at 28 days of the life is the lower end of the fusion occurs. And if this gets affected, that's when you start to develop spina bifida. So 28 days is a very important number that you have to remember. So by the time the neural pore closes, the posterior neuropore, if you have something which happens within these first 28 days, you can develop spina bifida. So that's an important fact for you all to remember. And then as time goes along, the lower end of the spinal cord, starts to develop further. So within the first third month of life, you can see that the spinal cord is going all the way down to the lower sacral region. And then by the time end of the fifth month, you can see this the spinal cord is rising higher up in the spinal column. And then when the newborn is there, you can see that the spinal cord ends at the lower end of L3, which is still lower down, because in adults it's at the at L1 and L2. So this is how the development of the lower end of the spinal column and the spinal cord occurs. And then if you have problems occurring, and this is the time of the secondary neurulation, where you can get something like cauda equina syndrome, which can happen when there is some problem during the pregnancy, in the later part of the pregnancy. So this is the normal development. So what happens when you have disorders which occur in this age? So when I skipped that one slide, but if you're looking at it in the first few days after the conception, if the insult is very early on in the first 2 to 3 weeks, the whole neural tube does not close, and you have a condition which is called craniorachis. It means everything is open from top to bottom. Toward the end of the third week, if only the top portion doesn't close, you'll have what's called anencephaly. And then if you have towards the end of the fourth week, you can end up getting spina bifida. And all these are primary neurulation defects. And then after 4 weeks, if you go on to the starting of the second month of gestation, when you start getting defects there, you can get secondary neurulation defects, where you can get spinal dysraphism with lipoma, that's the spinal cord lipoma, which is there, or lipomelingocele, which can occur at that age. Encephalocele can occur even a little later on also, and that's also sometimes a cause of a post-neurulation defect. So that's the early things that you're going to look at when the neural tube is closing. And the spectrum can be very wide. So you're looking at here, this whole thing is craniorachis. It's kind of horrible, and child cannot survive when the child has this. So you can see that the entire spinal cord area and the brain area, everything is open to the atmosphere here. Then you can have anencephaly, you can have encephalocele. Anencephaly is one of the less common conditions here. And then if you're looking at the spina bifida, it can range from spina bifida occulta, where you just have missing posterior elements of the vertebral bodies, or you can have a lipoma, where you have lipomeningocele, or you just have a meningocele, where you have the contents of the spinal column, only the meninges which outpouch, or the meninges as well as the spinal cord outpouches, and then you get a myelomeningocele. So those are the various grades of deficits that you can see with early defects in the defects early on in pregnancy, and the various causes can be multiple. So it can be a multifactorial thing, and one of the most common or most important aspect is folate antagonist. So that's why if you have anticonvulsants like carbamazepine, or you have valproic acid, all these are folate antagonists, and that can disturb the folate metabolism, and that can end up in spina bifida. So that's why when you talk about anticonvulsants being given in patients with epilepsy, you have to see that how early on, and your planning has to begin even earlier. So you have to make sure that they are not deficient in folate. You have to supplement them with folate even before they plan to become pregnant. There are other things which also can get affected. So if you have hyperglycemia, that's poorly controlled diabetes mellitus, that can also give rise to lower spinal cord secondary neurulation defects, deficiency of various vitamins, and then hyperpyrexia, as they call it, hyperthermia, in very early on in pregnancy. The exact mechanism is not known, but that can also give rise to problems with the spina bifida and other conditions of the primary neurulation defects. So this is an example. Actually, this is in downstate just last year, where a baby was born and the mom was not on any kind of a prenatal care. And you can see this is kind of horrible defect that we see here, this whole huge outpouching of this. So you have what's like the anencephaly and encephalocele, all the brain matter is all out there, and you just see a big cystic structure in this area. And if you're looking at the MRI, we can see that the whole thing is disrupted, and then brain matter is all scattered there. Baby survived for like 4 or 5 days and then died in the ICU. So this is one of the extreme cases. On the other hand, you can have the lower end of this cord, where you have the myelomeningocele. So the extent can be, this is a picture from the textbook. So extent can be, you can have a large defect, can have a little bit of smaller defect and even smaller. So these are various types of defect. This is closed, but this is an open defect, and that can lead to various problems when you have this sort of a defect, and it's an immediate neurosurgical emergency when the baby is born. And thankfully, the incidence of these is going down considerably because of folate administration as well as antenatal care, where you can do prenatal surgery, which can be done for this fetal myelomeningocele, and that has helped improve a great deal to see such defects, and these are not so commonly seen nowadays. This is an example of a baby who was born again here in downstate following poor prenatal care, and then the mom came in, and just before the baby was delivered, the antenatal sono showed that there is a defect there, and then the baby was delivered by C-section and had a defect in the back there, and an MRI was done, and you can see the clear-cut evidence of a myelomeningocele. The spinal cord is kind of hypoplastic there and thinned out, and the lower end of the spinal cord is here. Everything is projecting out, and you can see the myelomeningocele there. And this is the coronal axial view of this. In addition to what we see here in this defect, as you go higher up, you can see that the lower end of the brainstem is also all the way down into the cervical canal. The cerebellar tonsils are also down. This anatomy here is also abnormal. So these are characteristic features of Arnold-Chiari type 2 malformation. So it's almost exclusively 97 to 98% of patients with myelomeningocele will have Chiari 2 malformation. And the main characteristic features are inferior displacement of the medulla and the fourth ventricle into the upper cervical canal, like I showed you. You can have elongation and thinning of the medulla and the pons, and you can have beaking of the tectum. It's not very well seen here, but if you go higher up in the area of the midbrain, so actually I should show you the sagittal view of the brain, and that will show you the beaking of the tectum. You can have inferior displacement of the lower cerebellum, that's the cerebellar tonsils, into the cervical region. And this may also be associated with a variety of bone defects in the foramen magnum, in the occiput, and the upper cervical vertebrae. So this is all together forms the Chiari type 2 malformation, which is present in 97 to 98% of patients with myelomeningocele. And this is something that you guys should know even for your exams. So this is one of the major malformations that you should be aware of. As you go along, if the defects are not as devastating as these are, and the abnormalities are more towards the second month or the third month, you can end up having other malformations, things like lipomeningocele, lipoma or the teratoma within the lower end of the spinal cord, or you can just have a dermal sinus or a tethered cord without any of these malformations. So these are the caudal neural tube defects, which you can see in some of the children that are born there. So this is an example of a child who you can see the lower end of the spinal column. You can see that the spinal cord ends a little bit low, and this all hyper intense thing, which is continuous with the subcutaneous fat in the lower end. And this is a classic appearance of a lipomeningocele. And when you have the lower end of the spinal cord kind of adherent to this also has the appearance of a tethered cord, and this needs surgery because patient will have bowel and bladder involvement too, and if you don't treat it early, then that can leave behind GU problems in the end there. Another example is there is a diastematomyelia. You can see the spinal cord is split into two, and each one of them has a central canal within. So this is also another defect which can be seen as a part of the malformations in the lower end of the spinal cord. So diastematomyelia. So those are all related to the neural tube closure and then the spinal cord malformations. Now going higher up, the formation of the cerebral hemispheres and what are the malformations that you see as a result of those malformations in that area. So in order to know that, you need to know what normal development is in the upper end there. So normal prosencephalic development. So when you use the term prosencephalon, it is in the upper end of the neural tube, and the prosencephalon develops into the cerebral hemispheres, the cerebellum, and the midline structures. So the first thing which happens is that you start to develop the prosencephalon. That begins at the rostral end or the upper end of the neural tube within the first month after the closure of the anterior neuropore. Once the prosencephalon develops, then it starts to divide. That happens during 5 to 6 weeks of gestation. If it divides in different planes. In the horizontal plane, when it divides, it forms the optic vesicles, olfactory bulbs, and the tracts. Transversely, it divides to form the telencephalon and the diencephalon. So telencephalon forms the two cerebral hemispheres, and diencephalon forms the thalamus and the midline structures. It divides sagittally to form the two cerebral hemispheres. So that's why you have to divide it into left and right, and then the lateral ventricles and the basal ganglia. After the cleavage of the prosencephalic structures happen, then the midline structures start to develop, where this happens during the second and third month of gestation, where you develop all the various commissures and the chiasms. So that's why you have the corpus callosum, the septum pellucidum, the optic nerve chiasm, all those structures develop in the midline. So this is what happens normally within the first 3 months of gestation. So this is just a pictorial representation. So in very early on, this is like around 4 weeks, you just see the rudimentary nervous system. The purple is the area of the neural tube, which is the spinal cord at the bottom. The green is the area of the rhombencephalon. That divides into metencephalon and myelencephalon. The myelencephalon forms the brainstem. Metencephalon forms the pons. Mesencephalon forms the midbrain. And prosencephalon will form the cerebral hemisphere. So that's why you can see the whole thing here. It forms the telencephalon and the diencephalon, which is the forebrain. Telencephalon is the cerebral hemisphere, diencephalon is the thalami. So that's how the whole development occurs early on in the first 3 months of gestation. So when you have defects happening at this stage, there can be a lot of problems. Oh, this is the development of the commissures at the age of 4 months of gestation. So you have the corpus callosum, which starts to form, and you can see the outline of the body of the corpus callosum, the anterior commissure, the optic chiasm, all these form around the 4th month of gestation. So when you have disorders, the various malformation that can occur can be depending on when it occurs. So if the prosencephalon itself does not form, you have aprosencephaly or atelencephaly, means the brain does not form at all. Once the brain forms, but there is no cleavage, then you have the holoprosencephaly or holotelencephaly sequence. And then the next stage, once you have the cleavage occurs and then the cerebral hemispheres divide, if you don't develop the midline structures, you can end up getting agenesis of corpus callosum, agenesis of septum pellucidum, septo-optic dysplasia, and other midline structures there. So let me show you some examples of that. This is the same thing when you have problems with the agenesis of the corpus callosum and septo-optic dysplasia. So here, there are some pathological specimens which will show you this aprosencephaly. The cerebral hemispheres have not formed at all. Holoprosencephaly is where you have the cerebral hemispheres which are formed, but it's not divided. So you have a single ventricle here and the midline structures are fused. Here, the commissures are not formed at all. A milder form is there where you don't have the septum pellucidum, as well as the optic chiasm are hypoplastic, which forms the septo-optic dysplasia. Here you have the optic nerves which are formed well, but there is no septum pellucidum, so it's only agenesis of the septum pellucidum. And then you have finally the corpus callosum does not form at all, and then that's why the agenesis of the corpus callosum. So let me show you some examples of these here. This was a baby who was born here in downstate and antenatally diagnosed, but then due to religious reasons, they could not terminate the pregnancy. So you can see that this is a single cerebral hemisphere, single ventricle, and then you have a dorsal cyst. So this is the classic appearance of what's called alobar holoprosencephaly. And this is in the newborn period. If you miss it in the newborn period, or they're born in a place where they don't pick it up, you can have a child who comes in later on. So this is a 4 or 5-year-old child who came in with significant global developmental delay. And then you can see that there is again a single ventricle, single cerebral hemisphere, not hemisphere, single cerebrum, and then a posterior fossa cyst. So this is the classic appearance of holoprosencephaly. So when you talk about holoprosencephaly can be divided into different types. Alobar, which is the most severe type, where you have complete lack of separation of the two cerebral hemispheres with a single midline ventricle, and then the interhemispheric fissure and corpus callosum are absent. The next form will be semi-lobar, which is the intermediate form. The anterior hemispheres are not separated, but there is some degree of separation of the posterior hemispheres. So when the anterior is not separated, the genu and the body of the corpus callosum do not form, but the splenium is present posteriorly. Frontal horns of the lateral ventricles are not formed, but the posterior horns are present. And then lobar holoprosencephaly, where you have the lack of separation of the most rostral or the ventral aspects of the cerebral hemisphere. So that means the splenium and the body of the corpus callosum are present, but the genu is absent. And then one more variant, which is often described along with holoprosencephaly, though it's not exactly that, is called midline interhemispheric variant, where the midline structures are a problem. So the mid portion of the cerebral hemispheres become continuous over the midline, and there you don't have the corpus callosum, but the frontal lobes and the occipital lobes and the basal forebrain are separated. So some people include that as a variant of holoprosencephaly, some people may not. So these are the different types of holoprosencephaly. And these often occur in setting of major chromosomal abnormalities. So 60% of all holoprosencephalies are because of chromosomal abnormalities, of which chromosome 13 is the most commonly present. So when you have in your in-service exam or your board exam, chromosome 13 is associated with holoprosencephaly. Remember that. Other less common will be chromosome 18, and then some of the other smaller chromosome deletions and trisomies. 25% of holoprosencephalies can be because of monogenic abnormalities. So things like Smith-Lemli-Opitz syndrome, which is autosomal recessive. You can also have non-syndromic when you have mutations in certain genes, like the sonic hedgehog gene and things like that. And it can also be as a result of various teratogenic agents and different poorly controlled diabetes, etc. All those things can also give rise to holoprosencephaly, though it's much less common. The most important things are chromosomal abnormalities, which give rise to holoprosencephaly. Now, when you're looking at beyond holoprosencephaly, you can have what you see here classically is absence of the corpus callosum. So this is a classic appearance of agenesis of corpus callosum. You can see the cerebral hemisphere is very nicely formed, the cerebellum, the brainstem, you can see the thalamus, but you do not see the corpus callosum in between. And then when you're looking at the axial images, if you see parallel ventricles, that should make you suspect. So even on a CAT scan, when you see parallel ventricles, you should suspect agenesis of the corpus callosum. And that can be associated with interhemispheric some abnormality. Sometimes you have a cyst here. Sometimes you have interdigitation of the sulci and gyri, that region. And that should make you suspect that there is agenesis of the corpus callosum. Agenesis of corpus callosum is a very, very wide spectrum. And there are a ton of abnormalities which can give rise to that. It can be completely asymptomatic, or it can be associated with major syndromes. So some of the syndromes that you can talk about are Walker-Warburg. Some of the things can be, Soto syndrome, lissencephaly. They can also be associated with agenesis, X-linked syndromes. You also should remember some metabolic disorders can give rise to agenesis of the corpus callosum, most notorious being non-ketotic hyperglycemia. And then they can be associated with other CNS malformations too. So agenesis can be a very wide spectrum of clinical presentations. So that's the cerebral hemisphere's formation. Then next you come to the time where the neurons start to proliferate and increase in number. And this is around 3 to 5 months of gestation. Proliferation, migration usually go hand in hand, but I'm going to talk about proliferation first and then migration after this. So if you're looking at the peak period, 3 to 4 months is the time where the neuronal proliferation occurs. And they can be the neurons which form, as well as the glial structures which form, which are important for the other things like astrocytes and oligodendrocytes, which are important as a part of the various aspects of the brain structures here. So if you're looking at the number of cells in the brain, you can see it starts to exponentially increase somewhere between 10 to 20 weeks of gestation, both the neuronal and glial elements, and they continue to increase. The glial elements especially continue to increase after birth and increase in their formation depending on the glial structures can help to form the myelin and other things. So that's why they continue to function after the baby is delivered. But the maximum neuronal proliferation occurs within the 3 to 4 months of gestation. So this is an example. If you're looking at pictorial representation, the ventricular zone has all these precursor cells, and these start to divide and multiply, and then the processes start to form. So the ventricular zone and the marginal zone is seen. Then you start to develop the intermediate zone where you see the neurons start to, align themselves. And so also the other interneurons and the glial structures start to form. Then you start to see many other layers. So you have the ventricular zone, you have the subventricular zone, you have the intermediate zone, you have the cortical plate where all the neurons are started to form. And then you have the marginal zone. And then this starts to differentiate even more. So these are all the steps of normal proliferation and organization of the various layers of the cortex. And if you have problems happening here, you can end up having various types of malformations. So what is the disorders of neuronal proliferation that you see? The grossest ones that you see when you involve the cerebral hemispheres is microencephaly or microcephaly and macrocephaly. And if it is asymmetric, then you can end up having what's called hemimegalencephaly, with one of the cerebral hemispheres affected worse than the other. You can also get polymacrogyria. And if it affects the cerebellar structures, you can develop Dandy-Walker malformations and the various spectrum of the Dandy-Walker, including Vermean and cerebellar hypoplasia. So the causes, again, tend to be much more genetic, and they tend to be either autosomal recessive or autosomal dominant. Teratogenic effects can also happen, especially with fetal alcohol syndrome and various infections. All those things can also give rise to the microcephaly, which is a first form of the neuronal proliferation disorder. The genetic causes include trisomy 21, trisomy 18, trisomy 13, and various syndromes. All of them can be associated with microcephaly. The classic microcephaly, which is not associated with any other syndrome, which is called primary microcephaly, is just that the whole brain has less amount of neurons and less amount of proliferation which has occurred. And this is just to show you a comparison, which is most often autosomal recessive form of microcephaly. So this is a normal MRI of the brain. This is the microcephaly. You can see all the structures are formed, but they're all much smaller in dimension. That's the primary microcephaly. Secondary microcephaly can occur because of destructive causes too. So this is an example of where you can see a calcification. This is the newborn brain. That's why it's very hazy, and it's a preterm newborn. So that's why you don't see the sulci and gyri very well formed, but you see calcification here. So this was a baby who had actually, the mom had toxoplasmosis, and then baby had ended up having a toxoplasma infection, and that's resulted in microcephaly. So this is an acquired cause of microcephaly due to congenital infection. So that was microcephaly, and then you can have macrocephaly. Again, it can be associated with a whole lot of syndromes, which I'm not going to go over. This is an asymmetric form of microcephaly where you have hemimegalencephaly. So you can see the left hemisphere of the brain is much larger. So it's an asymmetric microcephaly. You can see that the cerebral cortex and the structures are like a package area. The sulci and gyri are very different from the other side. So this is an example of a hemimegalencephaly, which is another form of a macrocephaly. When you have structures in the posterior fossa which are affected, the classic thing is Dandy-Walker malformation. So Dandy-Walker malformation classically is associated with enlarged posterior fossa and the fourth ventricular cystic dilatation with Vermean hypogenesis or agenesis. So the cerebellar vermis is absent, and then you can have a whole lot of associated malformations. Hydrocephalus may not be present in the beginning, but 85 to 90% of children with Dandy-Walker syndrome will develop hydrocephalus by the end of the first year of life. So here is an example of a newborn baby who has a large cystic looking thing in the posterior region. But if you go lower down, you can see that the vermis of the cerebellum is not formed. So this is an example of a Dandy-Walker malformation. And this child grew up and ended up having hydrocephalus and a VP shunt, which needed to be put later on for the decompression of the shunt. So this is a Dandy-Walker malformation, which is the malformation of the posterior fossa. So that was about the neuronal proliferation. Are you guys following me, or am I just talking to empty space? I'm taking a break.
We're following.
Hopefully, I'm trying to give you a lot of information, and that's why I'm talking fast. Maybe if you guys can want to look at it later again, then you'll be able to follow some of the things that I'm trying to tell you. So the next step is neuronal migration. So when you're looking at the neuronal migration, it starts from the periventricular region and goes all the way to the cortex. And like I mentioned to you earlier, the ventricular zone is where all the precursor cells are, and then you have them travel through the various layers all the way up to the cortex. And then you have the various zones which form there. So ventricular zone, inner subventricular zone, outer subventricular zone, intermediate zone. Cortical plate is where all the neurons finally go to settle. And then the marginal zone where you have the various fibers which are present there. The peak time, again, of neuronal migration is going along with the proliferation. So it's around 3 to 5 months. So the major events that occur in the cerebrum and the cerebellum is that there is a radial migration of these various neurons all the way up to the cortex, as well as a tangential migration, which forms the interneurons. In the cerebellum, radial migration forms the Purkinje cells and the dentate nuclei, and the tangential migration causes the internal granule cells to form. This is too wordy, so I'm going to show you an image here. So the migration can occur very early on by the whole body of the cell. That's called the soma. So it's also called somal translocation. So the whole body moves from the ventricular zone all the way to the end of the cortex. And then later on, when the radial cells develop their processes, the soma can move along with the radial gyra and then travel up to the cortex. And always, the earliest migrated neurons are the most inner layer, and then the more later neurons which migrate are in the outer layer. So inner outer distribution of the cortical cells which are there in the cortical plate. And these are all very, very closely controlled by various genes and various molecules which are important for the migration of these various things. So this is another pictorial representation, which is which shows you how the ventricular zone is full of these neurons, and you have the other neuron, the other axillary. Oh my God, I lost my words. Radial migration which occurs, and then the interneurons which start to develop in these areas, and then you can see how the radial migration occurs all the way up to the cortex, and you can see the neurons are migrating all the way up. So this is another just a pictorial representation to show you all the way from 7 weeks to 13 weeks how the whole histology is so different in the prenatal period. Like I told you, these are all controlled by a host of molecular and genetic structures and chemicals. So you have the various things like the laminin and the relin gene, the double cortin gene, the filament gene. All those are responsible for all these migration. And if any defects occur in any of these genetic markers, you can end up getting malformations. So what are the various malformations that you can see when you have migration defects? In the cerebral hemispheres, we have it again 3 to 5 months of age. The spectrum is anywhere from schizencephaly, lissencephaly, all the way to heterotopias. If you have a cerebellar malformation, it can be Joubert syndrome, or you can have rhombencephalosynapsis, which can occur, which is very uncommon. So let me show you some examples there. Schizencephaly. Schizencephaly can be type 1 or type 2. Type 1 is where the lips are closed, opposed, and they do not communicate with the lateral ventricle. Type 2 cleft is its open lip and connects the subpial space with the lateral ventricles. Schizencephaly can be unilateral or bilateral. And as a result, the clinical manifestations can be again varied. It can be completely asymptomatic depending on where the schizencephaly is, or it can end up having severe neurological disabilities if you have bilateral type 2 deficit. So this is an example of bilateral type 2, where you can see the whole thing seems to be as though there is anterior and posterior parts of the brain, but actually it's a cleft and the lower part of the brain is connected. And you can see that the cleft is lined with the gray matter, both sides. And that's how you identify that it's a disorder of migration and not a destructive process like bilateral infarcts, because bilateral infarcts is a destructive process which will not be lined by gray matter. You have the lining, which is where you can see the gray matter clearly. That is more likely to be a schizencephaly cleft. So this is an bilateral open lip schizencephaly where you have a very, very neurologically impaired child. On the other hand, you can have just a unilateral schizencephaly, a unilateral cleft. Here, actually, the cleft is going all the way from the pia all the way to the ventricle. So this child is not completely asymptomatic. This child actually had hemiparesis because it was in this region where the motor cortex is, and also had intractable epilepsy. So this is another example of schizencephaly, which is not as devastated, but still has neurological deficit. And you can see how this cleft is lined with the gray matter here. So that's how we identify that this is not something which is destructive, but it's more of a malformation. Next, disorder in the migration is lissencephaly. Lissencephaly is also called smooth brain, and this is definitely something you will always be asked either in your in-service or in your board exams. And the severity of lissencephaly and the subcortical band heterotopia varies according to what you see on the image. So grades 1 and 2, some people use the grades, some people don't use the grades. So grades 1 and 2 are complete or near complete age area or a complete smooth brain. Grade 3 is where you have both age area and package area. So you see some sulci and gyri. Grade 4 is only package area. And grade 5 is where you have the package area as well as the subcortical band heterotopia pattern. So here are some examples. So this you can see is a complete, nice, smooth brain, very thick looking cortex here. And this is a child who has microcephaly and severe neurological impairment, global developmental delay, intractable epilepsy. So this is one of the classic type 1 lissencephaly. On the other hand, here you have another child who has some sulci and gyri. Along with that, you can see there is a band of white matter here and another band of gray matter. So that shows you that there's also a degree of band heterotopia there. So this will be the mixed type where you have type 2 or type 3 type lissencephaly. Another variety is where you have anterior part of the cerebral hemisphere showing some division, whereas the posterior part is more severely affected. So you can have various gradations of lissencephaly depending on when the deficit occurs, whether it's early on at 3 months or more towards the 5 months where some of the migration has already occurred in these. And these are all governed by different genetic control. So LIS1 tends to be, can be grade 3 or grade 4. But then if you have something which is Relin or the ARX, that can give rise to different types of the genotypic and phenotypic correlation that you want to see. You can see that they can be associated with band heterotopia, or it can be isolated lissencephaly, or it can be a combination of both. So these are all, again, governed by many genes and gene material there. Some people try to, associate. If you see a particular type of a pattern, then maybe you can predict what the genetic defect may be. So extreme right lower corner is a normal cortex. And then if you try to see various types of lissencephaly that you see, you might be able to predict what the gene defect may be. So here you have a very smooth brain, but you also see 2 layers. You can also see a band heterotopia there. So this is classically seen with double cortin gene problem. So that's the gene defect here. But at the same time, you can also see a little milder effect with the double cortin gene too. Double cortin gene also can give rise to subcortical band heterotopia. So it can be various types that you see. LIS1 can again give rise to much more of a smooth brain with some band heterotopia in the posterior region. So they try to do some genotype-phenotype correlation of the defect that you see with various types of lissencephaly. Important thing that I showed you that the cortex is very thick but very disorganized. So normal cortex has 6 layers, whereas the disorganized cortex of lissencephaly has only 4 layers, and all the neurons are all aligned in a different way, and that makes the whole thing much more susceptible to epileptogenesis and intractable epilepsy because of these various the way the neurons are misaligned and the layers are not appropriately formed. So remember that normal cortex 6 layers, lissencephaly 4 layers. So this is something that you are often asked, and that those 4 layers are very abnormally aligned. Going further, you can see here that within the ventricles you have these bumps here. So this is the classic appearance of periventricular nodular heterotopia. So this is another form of a migration defect where several of the neurons are still remaining within the periventricular zone and everything is not migrated, but a lot of the remaining structures have migrated. And this can also be a spectrum of malformations there. Most common malformation, most common manifestation of periventricular nodular heterotopia is usually seizures and epilepsy. Depending on what the defect is, the X-linked variant can be only periventricular nodular heterotopia. If it's an autosomal recessive variant affecting the chromosome 20, you can end up having microcephaly and global developmental delay. So these are the types of periventricular nodular heterotopia with associated malformations, it can be associated with double cortex. That will be a much more severe malformation. But only isolated periventricular nodular heterotopia can be associated with X-linked, which is the most common one, or it can be associated with chromosome 5, 6, or 7 defects, depending on where the problem arises. So like I said, the most common manifestation tends to be epilepsy in these patients. I'm going to skip this because this gives you all the genetic malformation in the various defects that are seen there. Then you see the malformation in the posterior fossa. So this is a classic appearance of the molar tooth sign of Joubert syndrome. So that's the posterior fossa malformation related to neuronal migration. And this is the appearance on the axial image where you can see the molar tooth sign. And then on the sagittal image, you can see the degree of malformation which is existing in the posterior fossa. So what are all the features of the Joubert syndrome? You have a small dysplastic vermis. You have elongated, thick, horizontally oriented superior cerebellar peduncles. And as a result, you get a triangular fourth ventricle shape. The interpeduncular fossa is very deep, and the pontomesencephalic junction becomes very thinned out. So those are the classic appearances of the Joubert syndrome on the MRI appearance for Joubert syndrome. Even less affected would be what's called the focal cortical dysplasia. So that's the most, how should I say, least malformation that you can see in the neuronal migration defects. So if you're looking at this is an MRI of a 14-year-old, and you can see in the posterior region here, you see this hazy shadow here. This is the region of the focal cortical dysplasia. So you can see that very clearly. There is an area here where the gray matter is there all the way down to the into the white matter, which is not supposed to exist. And this patient had intractable epilepsy as a manifestation. So focal cortical dysplasia is one of the migration abnormalities. So again, in order for you to remember, normal cortex, 6 layers. In focal cortical dysplasia, you have a highly disorganized cortex. And you can divide the focal cortical dysplasia into different types, type 1, type 2, type 3, type 2A, type 2B, based on whose classification you use. The most important thing will be you will have associated balloon cells. So balloon cells, you can have focal cortical dysplasia with balloon cells or without balloon cells. And the classic one, type 2B with balloon cells, is the one which is most commonly associated with intractable epilepsy. And you need epilepsy surgery to take out the area of the focal cortical dysplasia. So that's a classic thing which you have to know. Focal cortical dysplasia, balloon cells. Then finally coming to organization. And this is something which happens after 5 months to the postnatal period. So what happens during the organization? So the various structures which are already formed, so like, for example, the subplate neurons, they become more established and more differentiated. The lamination occurs, the various alignment and orientation and the layering of the various neurons in the various areas. So layers 1, 2, 3, 4, 5, 6, all that starts to organize at this rate. The growth of the dendrites and the axons start to form, solidify in this time. Synapses start to form and become more organized. And then as a part of this organization, you also have programmed cell death and you have the pruning of the synapses. So everything that forms in that region does not always stay, and you need to have cut back of some of those synapses and the neurites. And that is important in order for proper development to occur. In addition to that, you also have the glial proliferation and differentiation, which occurs. So when I was telling you about the synapses, the first synapses usually develop in the subplate neurons, and then the synaptogenesis in the cortical plate is most active in the postnatal period. Remember that approximately 40% of the synapses are subsequently eliminated. If you do not eliminate these synapses, they can result in certain disorders. Normal myelination also starts somewhere around the end of the gestation and continues till the several months postnatally. So what happens is the oligodendrocyte proliferate, migrate, differentiate, and then form the various myelin sheaths. And then the rules of myelination is that they tend to occur from caudal to rostral regions. They start from the center and then go to either poles. Occipital region gets myelinated first, the frontal regions next, and then the temporal regions. It always is usually posterior to anterior development, which is the most important development which is there. The projection fibers get myelinated before the association fibers. So these are some of the common processes that happen. So this is just a pictorial representation to show you that myelination begins somewhere in the middle, then proceeds in the occipital, and then the temporal, and then the frontal areas there. And always the occipital region is myelinated first compared to the other areas. So when you have problems in these times, where organization and myelination, these can end up having various forms of problems. Very early on, axon development, you can have problems with agents of corpus callosum, but that's a major malformation which can have many other things. If your dendritic growth and synapse formation is not appropriate, if you have too many synapses and too many dendrites, you can end up having problems like autism, developmental disability, Angelman syndrome. They tend to have too many of these things which have not been pruned up adequately. If the synaptic rearrangement has not occurred appropriately, you can end up having Fragile X syndrome, Rett syndrome, and those are the things which you see in the pathology in these patients. When you have problems with myelination, if lack of myelination, you can end up having what's called cerebral white matter hypoplasia. If it's destructive because of periventricular leukomalacia, which is the white matter disease of prematurity, you can end up having, like what I said, periventricular leukomalacia. And sometimes nutritional and metabolic disturbances also end up causing white matter problems. And inherited white matter disorders like leukodystrophies is another important cause, which is obviously going to present later on, depending on whether it's the early onset or late onset white matter problems. I'm going to skip this. So I think I already mentioned this to you, where you have disorders of myelination is hypoplasia or periventricular leukomalacia, and then nutritional factors. Remember that all problems with malformation does not mean that you reached your diagnosis in the end. A lot of metabolic disorders can also have major malformations. So for example, if you're looking at mitochondrial disorders like the respiratory chain, that can cause cerebellar malformation. So just because you do an MRI and you get a cerebellar malformation, you don't stop there. You also have to make sure that everything is okay in the inherited disorders of metabolism. So glutaric aciduria, for example, can give rise to hypoplasia of the temporal regions. Cholesterol metabolism like Smith-Lemli opiates can give rise to holoprosencephaly. Peroxisomal disorders like Zellweger syndrome can give rise to various kinds of malformation. There's lissencephaly, polymacrogyria, dysgenetic corpus callosum. Dysgenetic corpus callosum is actually a manifestation of many metabolic disorders. So don't stop just looking at the MRI. Look for other disorders which can contribute to that, and those inborn errors of metabolism can have associated symptoms which need to be taken care of. So metabolic disorders can also give rise to major disorders of malformation in the central nervous system. So I kind of sped through it, and hopefully you guys have an overall idea. I don't know whether you have any questions. If so, please ask me.
Just a few slides ago, you were saying one of the factors for hypomyelination is breastfeeding. Is it lack of breastfeeding or lack of nutrients?
Lack of breastfeeding. Let's see, what does it say? Yeah, nutritional factors. So it's if the mother is deficient in something, then that can contribute to the whole thing. So I don't know whether you guys can get an overview, but this is an important thing that's often you come across in your day-to-day practice as well as in your exam. So, you have to know these things. And it's a lot of dense material. So I'm sorry, I apologize for that, but these are facts that you need to remember. And these are spring cherry blossoms in Brooklyn.